everyone, welcome. I'm John Lynn, the founder and chief editor at Healthcare IT Today. And today we're sitting down with two experts in patient engagement and population health and important topics here in healthcare today. And so I'm excited to have a nice discussion around patient engagement and where we are in this new world, kind of in the midst of COVID-19, and then also going forward when it comes to population health. And so I want to introduce our guests. We have first Suzanne Cogan. She's Chief Commercial Officer at SPH Analytics. Welcome, Suzanne.
Thank you, John. Nice to be here.
Yeah, great to have you. And then we also have Lisa Slattery. She's VP of Accreditation and Recognition at NCQA. Welcome, Lisa.
Great to be with you, John. Thank you.
Yeah, so I think patient engagement is kind of this buzzword we've heard forever. And, it's a great thing to have. But I think in the past, many people have corrupted it. I like to say marketers corrupt everything. And I think that's true with patient engagement. And many just use I would describe it as like a spray and pray approach to patient engagement where they just spam out everyone. But, is that broad-based patient engagement really just dead in healthcare? Or what do you think, Suzanne?
Well, I wouldn't say it's completely dead, because certainly there's still a lot of reason, especially during COVID-19, to get blanket messages out to your entire patient or member population, like what your policies are with regard to coming in for an appointment during the pandemic, for example. But I think we've certainly seen over the years that a very broad-based approach doesn't have the impact that the industry would want it to have. So, for example, several years ago, people would think about patient engagement as equaling a patient portal. And, everyone rushed to get the patient portals out and get people to log in because of the meaningful use money. And we saw, a pretty lackluster percentage adoption and utilization. And then did we actually see any positive outcomes to people's health because of it? I'm not sure we did. So, certainly a more targeted approach to and personalized approach to patient engagement is warranted now. We certainly know that different types of communication, different messages, and different modalities to communicate them in work for different types of people. So at SPH Analytics, we do a ton of CAHPS patient experience surveys every year. We do about, for example, 40 million phone calls a year, gauge people's experience of their healthcare. So that gives us a lot of insight into how different cohorts of a population respond and react to different types of messages and modalities. So we know, for example, that if we mail out questionnaires for a Medicare or older population, 20% of them will respond, versus a Medicaid population, which tends to be under 65 typically, only about 7% of them will respond. But conversely, Medicaid population or members have about a 4 times higher response rate to messages sent to their cell phones by voice or by text. So, that's one thing to think about. And I think this year in particular, we have to think about targeted messages more so than ever, because this is the year that closing care gaps, for example, for HEDIS measures is going to be super important, because so many people have foregone visits to the doctor and, for routine visits, annual eye exams for diabetics, or colorectal cancer screenings for people over 50. So, a broad-based outreach for those types of reminders might involve sending an email or putting a message in a newsletter, but that requires the patient to read the message, realize that it applies to them, and then take the initiative to actually schedule the appointment and show up at the appointment. Versus if the health plan or the health system is the proactive player in that relationship, it might look a bit different. The health plan or the health system might first stratify the population and find out who are my diabetics that haven't had an eye exam or a foot exam. Which ones of those are likely to be more engaged in their health care, and therefore which ones of those am I going to send 2 emails with followed up by an automated phone call, versus which ones am I actually going to spend the resources and the time to have a live person phone them, tell them about, the fact that they've missed an appointment, and get the PCP on the phone and schedule that appointment for them.
I think that's great, and those numbers are fascinating as far as engagement based on population. So I think that's really great. But it's really interesting because I think as I listen to you, what I hear is that technology is allowing us to really personalize the engagement for patients today in a way that would have been challenging before. I mean, I think there was some of it done before as well, but now we can do it at a scale that's much more effective. Lisa, what are your thoughts on this? What does it take to really make patient engagement effective, and how should we leverage technology? And maybe where is technology even the wrong place? It's interesting, the Medicare population, maybe the mailing is better, but hopefully the technology informs us of that as well. What are your thoughts, Lisa?
Well, I think that the data that Suzanne was sharing was really interesting because at the end of the day, we really just need to understand who our customers, who our patients, who our members are. And the more information we have, the better insights we have. And so all things don't work for all people, and there's different motivating factors. I can tell you I'm motivated by different things than my daughter, and my daughter's motivated by different things than my mother. And so so the more we understand through data insights, the better we can personalize the message in a way that it actually hits home with someone and motivates them to go and seek the care that they need.
Is that anything you'd add? And maybe even, let's extend this even further and talk about, how do you measure the effectiveness of it and really improve future responses, which is the end goal.
Yeah, well, yeah, I mean, I was going to say, kind of taking it back one step, the first thing that is required in order for the technology to be adopted is that the organizations who might purchase and deploy the technology and provide it to their members have to be incentivized to do so. And so nowadays that's much more prevalent, right? So health plans, be they commercial plans or governmental plans, already have an incentive to motivate their members to stay healthy. Healthcare providers now, as long as they're in a primarily value-based contract as opposed to more fee-for-service, also now have the incentive. So with that in kind of the economic incentive in place to push those technologies to the consumers, we also have in place now a proliferation of EMR systems, the ability to extract discrete data from them, interoperability standards that help in pushing data out to consumers, as well as having data available to analyze and stratify so you can get those very specific slices of the population in order to know how to communicate with them. So at SPH, we have this concept of what we call a smart patient engagement platform. And it starts with analyzing the data, and there are kind of 4 sets of data that we think about. So, the obvious set to stratify a population would be clinical data. You want to understand what condition somebody has, what care gaps they have, what their risk factors are. But maybe you also want to stratify data based on the likelihood that that patient is going to engage in their own healthcare. So we have, for the past 10 years, been building up an algorithm of healthcare engageability based on national surveys that we've done for the past 10 years, and understanding a patient's attitudes and behaviors related to their healthcare. So it helps us pinpoint, based on various demographic and clinical conditions, how likely a patient is going to be engaged. And knowing that for your population is going to determine, do I spend those really expensive resources to get on the phone with a patient and be really, really proactive, or is sending an email sufficient, perhaps to someone in their 30s and 40s, and email might be enough. So stratifying the population first. Another way to stratify it is based on their experience with the health plan or the health system. So every health plan and health system, is mandated by the government to measure their patients' experience, and usually that comes also with a financial impact. The higher performing in terms of experience health plans get higher star ratings, which leads to more money from the government. So understanding or slicing your population by their experience with the health plan might also make you or give you pause to think, how am I going to communicate with this particular cohort that has these conditions and are particularly unhappy with my health plan? Well, maybe I'm going to have a very different message and outreach modality to those. But then in terms of how do you measure the effectiveness? So, you know, once you've sliced up your population and you've used potentially different messages and different what we call modality paths. So I might do, you know, an email followed up by a phone call to one cohort of my population, and I might do a mail followed up by 2 text messages to another cohort of my population to get them to do whatever it is I'm wanting to do. But at the end of it, we always think about like a measurement or a feedback loop. So we encourage our own clients for whom we do CAHPS surveys to, you know, if they see something, some anomaly in their data, or they're not doing well in a certain area, do additional analysis and get that feedback loop so you're fixing what you measured. So we do the same thing. So after we do a kind of a stratified outreach to patients, we'll often do a follow-up quick survey to say, did you get that message? Did you do anything about it? Did it resonate? And that shows us for every type of cohort for a particular organization's population, what is having the most impact in terms of actions that population might take.
That's great. Go ahead, Lisa.
If I can, I think that, you know, these are all great leading indicators that you would identify as a plan to see is the outreach effective? Are people engaging where we want them to engage? But of course, the lagging indicator at the end of the day, you want to see those HEDIS scores go up. You want to see those CAHPS scores go up because those feed into, as Suzanne was alluding to, your STARS scores, your revenue, your value-based purchasing. And so not to mention just how are you performing in taking good care of your population.
I think that's great. And I think you guys both pointed out the importance of it from a financial perspective as well, to have them engaged. You know, I think your comments about sending mail versus text versus email. You know, I literally don't even get my new credit card because I check my mail so little, and I've had to like have it replaced twice because it just, you know, like I just don't check it. I told my lawyer, I said, if you don't send me it in an email, you're not going to get paid. So start sending an email. So I mean, I think, but you know, that said, I also help a guy with some tech support and a neighbor that if you don't send it in the mail, he's not going to pay you. So, you know,
that's me, right? I have a personal workflow where I get a bill and I have a little place to put my paper bills and I pay them once a month. If I get bills via email, they go into that mess of my personal email. I get all sorts of junk and I never address them. So, yeah, it's definitely
a challenge.
Mm.
And there's such a financial component to it, but let's also talk about, I mean, I think we need at least be self-aware that COVID-19 has changed a lot of things. So, you know, how has that changed from your perspective? Maybe you can start, Lisa, and Suzanne, you can chime in. You know, how has COVID-19 impacted it? You know, does it actually increase engagement because they're stuck at home? Does it decrease engagement because they're so burnt out? Or what are you seeing in that regard? And what's going to be that impact? And how are you, you know, counseling organizations that need to deal with it?
Well, I'll just speak to initially, it's hard to talk about COVID-19 without talking about the explosion of telehealth in reaching patients. And so this is the common topic that we are talking about a great deal at NCQA, because our plans have been asking, you know, what will count, what won't count in terms of visits, and towards HEDIS measures. And I know we have just released our 40 HEDIS measures that do allow for telehealth. And of course, there's some exceptions that we've made just around COVID. And one example would be the childhood with a well child visit, which, yes, you can do it. Can you do everything that you would normally do in a well child visit? Not really. Is it better than nothing? It absolutely is. So right now, because this is what we have, this is what we're going to manage. But it certainly has disrupted the entire healthcare system. And there are those who are who are accessing this care, especially in the behavioral health space. It's very, very, very good. But Suzanne has already alluded to what has happened in the space, which is a real pullback away from anything that is not specifically COVID related in healthcare. And so all of the preventive care that's normally sought during this time, not happening. Really concerned about chronic care management that may not be happening the way it needs to happen. And certainly one of the biggest topics we're talking about, in addition to telemedicine, is immunization. As we move into this, I want to say post-COVID world, but we're not even through it to say post-COVID yet. Yeah. So in the COVID world that we're in, how do we make sure that the flu shots are getting done, that the pneumovax is getting done in these high-risk COVID individuals, and then all of our children who have not had their normal vaccinations. Some of them will be going back to school, some of them won't, but how do we make sure as a system that we are really focused on getting those immunizations? And obviously, analytics is a key driver in figuring out who needs that outreach, how we need to set it up, how we prioritize, et cetera.
It's hard to do an immunization over telehealth, at least for today.
It sure is.
Until they can ship it. Even
you can
then,
figure that out, let us know.
Suzanne, any other comments?
Yeah, I mean, like to your first point, are people at home more and therefore easier to engage with? So yes, to a certain extent. There was an article in the New York Times in April, I think it was, where pollsters, kind of national pollsters, had calculated that they had a 25% higher response rate for calling people to do national polls because people are at home and they're picking up the phone. When they pick up the phone, they're willing to talk to somebody because they're lonely or bored. And we've noticed the same thing in our surveys. There's been a big increase in response rates. But then what do you do? Like, you could engage someone, but if they don't feel comfortable going to see the doctor, how do you get them to do what they need to do to take care of themselves? And so to Lisa's point, telehealth is, a really bright light there. We actually recently conducted 2 surveys. One was a national survey on just of healthcare consumers in general on telehealth, and the other is an ongoing one. We're tracking it every week for national consumers on just their perception of their health system and their health plan during COVID-19. So the telehealth one, we actually started it very kind of, as if we knew something in advance, although we didn't. We started it in January, so pre-pandemic, and we've done it kind of right after the declaration of the pandemic, and then the most recent one was a couple of weeks ago. So the rate of telehealth utilization, as in number of people saying that they'd ever had a telehealth visit, went from 11% in January to 35% most recently. So that was, that's kind of what you would expect, like a big increase. It'll be interesting to see, does that continue in the short term and longer term? But the other kind of interesting stat that we found from the other survey we've been doing is, despite the fact that we work with a lot of health plans, and so they tell us that they're doing a lot of outreach to their members at the moment related to COVID-19, giving them updates on policies related to copays or how to get a test or how to stay safe. But the members aren't hearing that. So in our survey, only 37% of people who responded said that they had heard anything from their health plan related to COVID-19. So it's another kind of question of, the message has to be delivered, but it also has to resonate with the consumer for it to sink in, for them to remember it, and for them to do anything about it. And then, as we've talked about, getting people to get back into the doctors, whether that's a virtual visit or an in-person, and having those routine checkups if you've got a chronic condition is so key. And in order to get that to happen, they've got to feel comfortable and safe and know, what kind of resources are available to them for care.
It's amazing to me how much of this problem is a marketing and communications problem, as much as it is a technology or a healthcare problem. And but I think that is the challenge that we're faced with. I did want to talk about one other thing, kind of related to some of what we talked about, and that's that some people have suggested that maybe we should stop doing a lot of the reporting measures in healthcare amidst the pandemic. Hey, we're distracted setting up hospitals, we're dealing with the crisis. So maybe we should stop some of these measures because they're a bit overwhelming or things like that. And this really feels like a question for you, Lisa, right? Why is it important to continue the reporting of things like HEDIS and CAHPS scores?
Well, it's really interesting to have this conversation today because just last night we, late in the evening, closed out our HEDIS for measurement year 2019, HEDIS year 2020. And there were a lot of concerns that plans had. And as you recall, CMS told Medicare plans that they did not need to report in order to prevent people from going into offices. The main was trying to access those charts for hybrid. And what we found really surprised us, and we had 96% of plans who were able to report their HEDIS. And so even plans that were not required to report chose to report for their own quality improvement efforts. And what that tells us is, and it's similar to what we've heard from plans and from the physicians that are in value-based contracting, that these measures are a critical component of our value-based infrastructure, our value-based payment infrastructure. And so it's critical to follow them. There's a lot of investments that have been made around those measures. And if you think about what HEDIS measures really are, it's the health effectiveness, right? How well are we following evidence-based guidelines, providing the preventive care, making sure that the chronic care management is there, making sure that just the appropriate things that need to be done are being done and that everyone has access to those. And certainly we've seen a huge health disparity with COVID. It has just exposed more than ever some health equity problems. So we want to make sure that we are evaluating how we're doing, that we're micro-segmenting, just as we do in the marketing and sales space. We need to do that in the healthcare space so that we can really understand what's happening. And we need to know, does telemedicine work for diabetes care, or does someone need to go into the office? Are there different types of patients that do better with different types of care? How will we know that if we stop measuring the outcomes? So it's really critically important that we continue to keep that quality framework, that we continue to use those HEDIS measures as front and center, the lingua franca for value-based purchasing in terms of health outcomes.
Yeah, and that makes sense from a HEDIS and CAHPS perspective because the infrastructure was there and built, and
Right.
I think many of them incorporated it into their models. I'm interested to see if the same will happen with things like the promoting interoperability, the MIPS and MACRA scores that are newer, and they essentially get an automatic exemption at least this year. So I don't know if you have any other thoughts on this, Suzanne?
Well, I was going to say that we were somewhat surprised a couple of weeks ago when CMS announced that CAHPS measures, their weighting is actually increased. So it's gone from a weight of a 2 to a weight of a 4 in terms of its impact on the star rating. So a lot of health plans provided some pretty negative feedback about that, saying, this is the time to, increase a CAHPS measure, and, we'd be questioning members about their experience. But CMS had the opposite response. They said, actually, the uncertainty of the pandemic makes it even more important for health plans to be focused on the patient experience and connect with benefits in a customized and supportive way. So, it's interesting that that they see this pandemic as a time to really lean in and understand more than ever the members' experience and communicate with them and help them out through this time. And in terms of kind of the MIPS quality measures, the ACO quality measures, We'll see how that plays out during the year. CMS hasn't come out to say whether they're going to be required or not, but even if they're not mandatory, I suspect that a lot of organizations will still measure them because they want to kind of keep track of how they're doing, because next year, when they become mandatory again, they don't want to have a dip. And B, it's, it does help them understand, how they're doing best patient care. And like I said, most of them are in some kind of value-based contracts. So the work that they do to understand their patient population in terms of MIPS helps them in their other commercial-based contracts.
Yeah, and it's nice. It's almost like a free trial-based period with no penalty if you decide, if you mess it up. So I think some could use it that way. That makes a lot of sense. So, what is the future? Is it kind of leaning into this patient engagement, or what does patient engagement look like going forward? You want to do Lisa and then Suzanne?
Well, I think that I'll just go back to understanding what each individual needs, that patient-centered approach, that person-centered care, that person-centered goal setting, evaluating whether or not we've met that. It all starts with reaching the people in a way that causes them to engage. I'm just looking, my phone today, I have a doctor's appointment tomorrow to establish with a primary. I really don't need to go in the office. I've gotten 3 text messages. I've gotten 2 emails, none of which I can respond to say, could I please have a telemedicine visit? Instead, I have to call them. And I've gotten, can you please hold, and been put on hold 4 times today. So I haven't been able to get through. So clearly, the approach is not working in a way that's going to be impactful for me. And I think that understanding what would work best for me, I'm a healthy person, a telemedicine visit would be great. It would be great if they could have figured that out without me having to go through all these steps to define that. And I think that the data and analytics piece is going to be critical moving forward in identifying which patients need what care, especially with this backlog of care that we're going to have. We know that we're going to have a capacity issue with this backlog of people needing care. And so we're going to need to prioritize and make sure people are in the right type of environment, who needs to be where, how do we get people the care that they need in the most effective way. And I think analytics is at the heart of that. And we really need to someday get to that holy grail of that integrated data analytics process where we've got a full picture of the customer, of the patient, of the individual, and their data sits with them as opposed to spread all out over the entire healthcare community.
Yeah, sounds like your practice needs to get a patient advisory board too. I think that would help.
Exactly. I'll volunteer.
Definitely. Suzanne?
Yeah, I agree with that. I think the further stratification to understand different cohorts of your population, which is so easy, relatively easy, I should say, to do nowadays with, EMR data, claims data, pop health tools to be able to stratify it, and thinking about what cohorts have similar characteristics from a demographic perspective, from a clinical perspective, from a behavioral / engageability perspective. And think about, in this day and age, we're going to need a cohort for high risk of COVID, right? Because you might want to reach to those types of patients in a different way. And taking the time and the effort to do that stratification and then have the different channels to reach out to them has benefits for everyone, right? So it should be able to keep patients healthier, close care gaps, which obviously is good for the patient. It's also good for the organization that's trying to comply with regulatory requirements or meet certain terms in their value-based contracts, improve quality rating. And then ultimately, it's definitely going to have an impact on that patient's loyalty if they feel that they're being communicated with in a way that's very personal.
Oh, that's great. And I'll make my own prediction at the end. Those organizations that do this well are going to thrive. And those organizations that don't personalize the engagement and don't personalize the experience are going to have troubles and probably fail, but they fail in the sense they'll probably be acquired and things like that. So thanks for this great discussion. I really appreciate your insights into this challenging topic, really, of how to engage them around population health outcomes. Thanks for coming. I'm John Lynn. If you want to find more great healthcare IT content, check it out at healthcareittoday.com.